I will also be joined on stage by Jeannie Pills. And again, apologies if I get the pronunciation wrong. Jean works as the PPP, Private and Public Partnerships Senior Officer at USAID. And since 2009, Jean has served as an advisor with USAID Tanzania. He was a Peace Corps country director in South Africa and the Peace Corps and training advisor for South Africa as well. He's led private sector projects in Ghana, Eswatini, Namibia. He's also worked with the USAID Office of International Training and later the USAID Africa Bureau in DC. He was actually previously based in Bayer as a USAID farmer training project and has his EDM and PhD from Illinois. He's also has expertise in vocational technical education, and we're really looking forward to sharing the stage with him. I also have the pleasure of inviting, a clap for Matt, a clap for Jean, my apologies. A clap for Jean as well. Now, I have the pleasure of inviting Dolorosa Duncan. Now, this is a tongue twister for me, so I'm taking it slow. Dolorosa Duncan is the country director for M-Mama, working with the Vodafone Foundation. And she leads a scalable innovation technology infrastructure that was developed in collaboration with the government of Tanzania to offer emergency transportation service for maternal and newborn emergencies. She's a former country lead for Girl Effect in Tanzania, and she comes with a diverse range of expertise and making a difference in the lives of more than 2 million girls across Tanzania. She's a former Africa University graduate and also has a master's in public health from London School of Hygiene and Tropical Medicine. She's an Eisenhower Fellow for 2017 and is actually leading the fellowship, the Eisenhower Fellowship Tanzania chapter. She's also an emerging voice for Global Health 2016 and sits on the Mwanza University Council and the Girl Effect Board. We do also have the pleasure of inviting Dr. Samueli Ogilo. Karibu sana, Dr. Ogilo. We'll just do a nice round of applause at the end. I keep forgetting that after every speaker, after introducing each speaker. Dr. Ogilo is the CEO of AFTA. AFTA stands for, is the umbrella organization for the Tanzania private sector. Dr. Ogilo has more than 900 healthcare facilities, manages under this network more than 900 healthcare facilities across Tanzania. He's a dedicated advocate for PPPs in health. He has played a significant role in promoting investments in the health sector in the whole of East Africa region. He served in several policy and strategy formulation committees, and has developed many innovative health programs across several thematic areas, including HIV/AIDS, NCDs, quality improvement in healthcare, etc. And we are really happy to have him because he's also led the establishment of a unique microfinance institution for healthcare in Tanzania, which is the Afya Microfinance. Asante sana, Dr. Ogilo. Has Mr. Macha joined us yet? If not, I will just read his bio in absentia so that when he comes, he's able to join us on the stage and we can continue. Tumainel Macha is replacing our Director for Policy and Planning, Amur, who was supposed to join us and unfortunately has not been able to. But we are happy to have Macha. Macha is the Assistant Director, Policy, Research, and Innovation in the Directorate of Policy Planning at the Ministry of Health. In his current role, he's been instrumental in advancing digital health transformation and has been involved in various initiatives in digital health, including DHIS2, that's important for data collection across the country. So we have our eminent panelists, and we will start this session officially. I will invite each of them to speak. I'm assuming we have a roving mic. Yes, thank you. I'll invite each of them to speak because we are trying to catch up on time. I know the initial instructions were for 10 minutes, but if you can keep it to about 7 minutes, that would be wonderful. I will take my seat. So, the first question goes to Matt. Karibu sana.
Asante.
Good. So, Matt, the question to you is, based on your extensive knowledge working across many countries, more than 50, and a lot of them in southern sub-Saharan Africa, and particularly in Tanzania, can you provide specific examples of policy barriers that have hindered PPPs and how they have impacted healthcare?
Excellent, thank you. So the area we work in is quite specialized. So we are 650 employees dedicated to one thing, expanding access to high quality kidney care. And sadly, across Africa broadly, if your kidneys fail, which about 1 in 8 adults have chronic kidney disease, and many of them will progress to a point in which the only way to stay alive is a transplantation or dialysis, the vast majority don't have access to that care. Over 90% of patients on the continent simply don't have access and they pass away. And so we are a company that is focused on transforming kidney care and expanding access to high quality care across the continent. When it comes to PPP, what we found is that often there's a great idea, right? So we can bring capital, right? We signed a financing round to give us $20 million to deploy to build new clinics. And most of these are in remote areas serving underserved populations that really need access to care. We have the expertise. Again, we're a large company doing one thing. And we also have the kind of scale advantages because we can bring entire shipping containers of machines and supplies and medications over to drive the price down. And so we can design a solution that's a win-win-win, right? And we've done that a lot. What we've found some of the obstacles to be is that you have a great idea, it's a good fit with the government, it aligns strategically, but then things just don't move, right? And so I think the areas where we've run into issues, number one is around bureaucracy. And there's important bureaucracy, right? Because these are big decisions, and they have to make sure that they're vetting partners very, very well. But sometimes things move very, very slowly, right? And so in the last year, we've built 25, this year we'll build 25 to 30 centers with mostly faith-based hospitals and some private hospitals. We do have 3 active public-private partnerships, but we found that sometimes the selling cycle on that can be 1.5, 2 years, right? And things move on. And so we owe it to the government to be very clear, very transparent about kind of how the model will work. And they owe it to us to try to move quickly and get stuff done. And so that's the first one. The second one, and I'm not talking Tanzania on this example, is to make sure that bribery isn't part of the game, just to be very direct. So we signed a PPP with the NHIF in Kenya, and I'm not going to name names, but we had a beautiful model in place that would expand access to care. We would build 20 dialysis centers in the counties, centers of excellence, state-of-the-art equipment. We would lower the price of care. We would do all the right stuff, improve quality. And a great concept, agreed centrally, and then we had to go to county governors. And very quickly, again, without naming names, it got into a what's in it for me type of a discussion. And we backed off and said, look, we're not going to play that game, right? And so again, both sides have a role to play in that because there have been bad actors that have kind of entertained that type of thing. And the third thing and final thing I would say is just typical barriers to investment. And so we're in 5 countries right now. And again, thanks to our friends at USAID and others that have given us additional funding, we are ready to deploy capital. I would love to deploy more of that capital in Tanzania and Zanzibar, right? But we need to move fast and we need to have the right kind of structure in place. We're building rapidly into Zambia, we're building in Rwanda, we're building into Kenya, And so there is competition for dollars, right? And so I think the typical barriers to entry around kind of tax regimes and straightforward tax policies, importation duties, and other things like that to remove as much of the red tape to let good businesses succeed and winning ideas prevail would be some experiences.
Thank you very much, Matt. A lot to ponder on, and the need for our policy environment to be more enabling, reducing the red tape and reducing some of the other governance issues, let me call them governance issues, that do prevent the adoption and scale-up of PPPs. I would love to then invite Dr. Ogilo, so that you can tell us from your point of view as the CEO or after, how can we effectively implement policy changes to ensure sustainable and impactful private and public partnerships in Tanzania's healthcare?
Thank you. I think we've been through that for the last 20 years, trying to see how we can transform policy issues, policy commitments into real action. That's what the problem is. Especially on public-private partnerships. In 2009, that's when we had the policy approved. We contributed much into it, and I think only the health sector had already lots of experience in public-private partnerships. This goes back pre-colonial in 1940s, 50s already. There are public-private partnership agreements between the government and private sector, especially faith-based organizations. So when we had this policy coming in, a lot was being reflected on the private health sector and how these PPPs have been successful. So we contributed a lot to that policy development. And then in 2010, we had the act approved by the parliament in Tanzania. And the following year, in 2011, this actually went very fast, we had the regulations approved on public-private partnerships. So this was the first in Tanzania, and we are so happy. And I remember by that time, we had already been working for about 5 years in a Ministry of Health Public-Private Partnership Steering Committee, which had done a lot already. So we are very optimistic. But now we came to the real issue, as you said, now transforming that policy into action. Now, as we can see, I think now 13 years, we're still working on it. It takes time. Why it takes time? Number one is that when you're implementing policies, you should have regulations in place and, of course, the acts that are going to support it. So we had those, and that was perfect. What comes in is now changing the mindset and what has been usual into reality, that things have got to change. So for a country like Tanzania, I think it was tougher. Because if you look backward from independence, we had about 20 years after independence, whereby our policies were changing, and we had taken the socialism direction. I'm talking about public-private partnership is really accepting capitalism to come in, whereby it can take advantage of private capital to support government or public initiatives. So that was hard to take. We have a lot of resistance from every corner. When it goes back to policymakers, they approved it, but then coming to implement it, they still feel like, are we betraying our former understanding and commitment? So that took a lot of time. And I think there's been a lot of changes. 2 days ago, we saw how everyone in this room, from the public sector, we are now accepting that public-private partnership is the way to go. And we have had lots of dialogue to make sure that this happens. So I think in Tanzania, the dialogues have worked. The discussions that we have had have brought in some good results. And also, we had few examples that could now narrate about the success of public-private partnerships. If you look in healthcare, 40% of healthcare in Tanzania is by the private sector. And therefore, supporting the government in that huge budget which the government would not have handled. And also, if you go further, just to show that the populations in Tanzania are utilizing the private sector well, and that's minimizing the cost for the government. If you look at people are covered by insurance in Tanzania, between 60 to 70% are attended in the private sector. So when you're moving to universal health coverage, that needs a lot of investment. The private sector has got a big role to play, and this must go through public-private partnerships. And therefore, you can see that the policy issues, yes, they're difficult, but we are somehow making a breakthrough now, and I think just a matter of time when it will not be an issue again. But what we'll have to do, discussions will be how much money can you bring in to invest in public goods as a private entity, and then go into lasting contracts on public-private partnerships. Thank you.
Asante sana, Dr. Ogilo. Thank you for reminding us that of the critical role that the private sector plays in delivery of healthcare in Tanzania, with more than 40% of services actually being sought from the private sector, and the call to action that we have to move with haste to implement the really solid and strong policies that are already in place. Now, for one of the really great examples of PPPs in Tanzania, I would like to invite Dolorosa of M-Mama to tell us a little bit more about this innovation, and then tell us, given the success of M-Mama, what are the key factors that drove this model to its success, and what are the lessons learned that can be used to scale up this across the rest of Africa? Karibu.
Thanks so much, moderator. Early birds, are you awake right now? Hello? Mpo jamani humu ndani? Mpo kimya sana, mlioko nyuma mngesogea mbele angalau tuwe jirani hata tufanye conversation. Tungeshukuru kama mngesogea mbele tuwe na conversation ili watu watakaochelewa waje wakae nyuma. Okay, thank you so much. You know, we are so grateful with the people who were really advocating for the PPP policy, because some of us sailed smoothly into this boat. So as for M-Mama, as you said, it's like a true example of how public and private can come together and make something which is really, you know, like a solution to the people. So the issues that really helped us to be where we are right now, the first one actually is that true partnership and collaboration between the private sector and the government sector. And what do I mean by this? You know, as private sector, we bring in ideas, technology, you know, resources. But for these things, you know, because we are, as the private sector, we are complementing the government efforts in really reaching everyone in the community. So in this case, the government came in with all the policies, guidelines, resources, and even the funding. So with M-Mama, we are not only co-implementing, but we are also co-funding with the government. For any program to be sustainable, for any innovation to be sustainable, it has to be, you know, like owned by the government. So the first secret was this, the true collaboration and true partnership. And this is not only between the government and the private sector, but even within the government itself. With M-Mama, we have 6 different ministries that are collaborating. We have the Ministry of Health as the sector ministry. We have PORALG as the implementing ministry. But we also have Ministry of Finance that is coming in because, for instance, the community drivers who are alternative drivers have to be paid, and they are paid directly by the government because all the running costs are paid by the government. And then we have MICIT, because now, as we know, now in Tanzania, and really we need to advocate for this, and I request everyone in this room to just remember number 115. If you have any emergency for mothers, like pregnant women, mothers under, like postpartum mothers under 42 days, and babies under 28 days, please call 115. Wherever this mother or a baby is, will be picked by either ambulance as the first priority. If ambulance is not available, they will be followed wherever they are by the community driver. Or they will be taken to a close place, to a boat, for instance in Zanzibar, where they can be transported by a boat to where the facilities are. So in this case, looking at that, that is like one of the major successes, just the true partnership among us. But the other thing is also affordability. Back in 2017 and even currently, like back in 2017, MUHAS did evaluating the cost effectiveness of M-Mama. And they really realized like it's very cost effective because by having M-Mama, by having an alternative transportation, we are comparing ambulance alone and ambulance with the community drivers and also community drivers alone. And really, we have less, 40% less costs by having M-Mama because we have an alternative transportation. We're reducing the timing, actually, the time to reach the mother who is in emergency. And also, in the beginning, we have few ambulances, for instance. You can find in a district, you have, for instance, 2 ambulances. And this ambulance has gone somewhere to take the client. So if you have to wait for 6 hours for that ambulance to come, and that ambulance has to go a very long way, that's more costful. You have to pay the driver, you have to pay extra cost for the service of that specific ambulance, and at the same time, you have to move, a very long way. While with the community drivers, you have the drivers where the client is located. So it's easy to just move a shorter distance than just depending on ambulance that comes from a very far. We really understand how ambulances are very important, especially in many cases, but, for the time being, because we have fewer ambulances, then we need to have alternative while we are waiting for that world where we can have like ambulances for covering every other population members. The other thing is also, the most important thing on us is like data-driven decision making. With M-Mama, we have, the real-time data. Our dispatchers are picking data immediately. And now we can even track, how many clients are on the way to the hospital at this point of time. Those data really helps leaders at different levels to make decisions. And now we have seen like an example that was given like the day before yesterday for the people who were in that plenary session. In the beginning, when we started M-Mama as a private sector in collaboration with USAID, when we were fully funding it, it was out of 10 trips, there were 1 ambulance and 9 were community drivers. But as we move, there's an indirect, like impact on the accountability, especially on the use of ambulance. Now, out of 10 trips, 8 will be ambulance, and then 2 will be community drivers. Why? It's because of those data. Because those data, they have so many eyes from the highest level to the lowest level. So in that case, people really feel very responsible. Their accountability has really been increasing. And in that case, the usability of ambulances has also increased to a great extent. And by having 8 trips does not mean that people also are delayed. No. It's because now ambulances have fuel. Now ambulances are being, serviced on time. And this is because of the data that is seen at all levels, and that is real-time data. Maybe for now, let me just end there.
Asante sana. Really great reflections there around some of the best lessons that we can take forward, including, actual buy-in for the true partnership with resources from both, from the different departments, the cost efficiency and the accountability. Asante sana for sharing that. Now, we do have another arm of the private sector, a private-public partnership here. Jean, you represent USAID on this panel. Could you tell us what role do development partners play in leveraging the private sector to ensure sustainability of health projects?
Sure, thank you. My role at USAID as a public-private sector advisor is to discover private sector solutions. Not create them, discover them. And there are so many out there, but I'm going to focus on one. We went to Gaeta, and there's a social enterprise there called Healthy Entrepreneurs. And a social enterprise is different than a for-profit enterprise in the sense that they don't have shareholders that expect a return on their investment. So they can focus all of their capital on pursuing social and public health returns, and it doesn't have to always be monetary. And when we took a look at Gaeta, we said there's potential. Then with some help of some USAID, other partners, a trip was arranged to go to Uganda, where 3 government ministries were there and other donors, we took a look at Uganda in their model, and Healthy Entrepreneurs covers more than 2/3, if not 3/4 of the country now. And they're working strictly with community health workers. And that has an immediate impact on what the government here is trying to do. Using the data provided by the government, by the ministry, we calculate that the cost of the current program as designed will cost the government around $79 million a year just in wages to pay for the salaries of 138,000 community health workers plus 16,000 supervisors. So how do we address that and make it sustainable? Well, the social enterprise in Uganda has a supply chain company that delivers products, hygiene products, medicine products, directly to the community health worker. Now, why is that important? Well, there are about 12,300 villages in Tanzania, but there are only about 6,000 dispensaries. So that means half of the community health workers will have a drop-off point where we can't find it because they don't have a dispensary. So how do you address that problem? Well, this social enterprise, that's what they do. They deliver the goods and products to the last mile. And how do they survive? They develop really tight contracts on pulled procurement that drive the prices of items down so that they then can pass on those savings to the customers in the villages. The community health worker gets a little bit of profit from the sale of the items, and then the social enterprise itself has enough money so they can continue to operate and grow. The surplus money is sent over to a foundation. That foundation then invests in supportive supervision and training. And that training is on a daily basis. They have call centers, and each person has a certain geographic area where they're in touch with those community health workers every single day. They also have the vehicles going out with supplies every 2 weeks, so they have more contact. They have tablets where they have information on public health issues that has been approved by the Ministry of Health. So they have information at hand. They can order materials. And so it is a solution that the government might want to take a look at. Depends how you want to do it. But my estimate is we could save the government a wage bill. Instead of being $79,000, we could at least reduce it down to $40 million a year. That's still high. But I'm sure as we continue to pursue and having conversations with the government, we can figure out other alternatives to make that work. So in short, that's what I do. Try to figure out where there are private sector solutions and discuss with the government and the donors how we can work together to make it work. Thank you.
Thank you, Jean, for the reflections there. You know, on one of the roles of USAID in this aspect around the discovery and a lot of the data and evidence that goes along with that and the advocacy for these initiatives, and for sharing that model that is actually has social impact and also is sustainable. There's a voice that we are missing in this discussion, and that's a voice of government, one of the P's in PPPs. We will hopefully come back to that if we'll be joined by Mr. Macha, but perhaps we can give him a little more time and take questions from the audience. If there are any questions for our 4 distinguished panelists, keynote speakers rather, we will welcome those questions now as we wait to see whether we will have government representation. Any questions around PPP? Yes. Karibu. Can I ask for support with the roving mic?
Yeah, thank you, moderator. Good morning. My name is Machmani Kiwanga from University of Dar es Salaam, PhD candidate, student for medical tourism from UDSM and the Open University of Tanzania. May I speak both language for convenience? Thank you. Yeah, ni mdau pia wa sekta binafsi tangu mwaka 2000 nikiwa mkoa wa Pwani na nikaweza kushirikiana na USAID through Care International, UNICEF katika programu za vijana. Changamoto mojawapo, niende moja kwa moja katika PPP ambayo niligundua, moja ni training at the beginning of the projects in terms of planning, process, implementation, monitoring, evaluation. Kwamba project zinakwenda katika community lakini hakuna maandalizi ya kutosha kwa ajili ya implementation. Inafanyika, pesa inaingizwa, watu wataanza kupiga migogoro pale na vitu kama hivyo. Mwaka kwanza wa pili project imekwisha, results kwenye monitoring and evaluation haieleweki. Data zinawekwa lakini not quality of data. Kingine ni issue ya trust kati ya mtoa na mpokeaji, na nyingine ni project management processes in general, kwamba kama dona unapeka project yako, wanao implement umewaandaa vipi ili mwisho wa siku tuone matokeo chanya kwa kila upande. Dona anahitaji nini na anayepokea anahitaji kuna mabadiliko gani ambayo ni serikali na jamii iliyopo. Asante sana.
So thank you very much. I'm not sure I'm the best translator in the room, but that was essentially a comment around some of the challenges experienced in his experience with PPPs, including the training, preparatory training to support implementation, including trust between the giver and the receiver, quality assurance, and monitoring as well. So more of a comment, right? Cool. Yes, I see another hand at the back and at the front. We'll take the comments and questions as one round and then respond to them together.
Thank you so much. My name is Victoria Marijani from Save the Children. I work as head of advocacy and communication. And thank you to all the panelists for the good keynote speech. So mine is on just a comment. So from the experience of working with private sector engagement, I've seen that the private sector expecting the government to build an enabling environment for the sector operation, the smooth sector operation. For example, the environment in terms of ensuring that there are smooth systems for paying taxations, all those things that have to do with the business operations, business running. But also they're expecting to receive capacity building for ensuring quality when they do their business operations. And the capacity building is very important so that the government can ensure consistency in terms of service provision across the sectors. But also the government should invest in terms of monitoring and evaluation so that the country can have harmonization in the M&E systems, that MIS systems that are used across the country. Because you find sometimes there are good things that are happening in private sectors, but they are not documented. They're not documented, the impact is not documented, so things are ending like that. But as long as they're ensuring increasing access in the communities and across the country, then we need to ensure that we have robust monitoring and evaluation systems across the private and the public sector, so that we can be able to monitor all the data and what is going on in the communities. But also for the private sector, they're expecting the win-win situation for them to be able to invest. We've seen in our work, they're expecting also to be recognized in the government, to be invited in the government technical meetings, but also for them to be recognized as contributors, especially in areas like nutrition that we are working in, nutrition, health, as well as child protection. Thank you.
Thank you very much, Victoria. We'll take one last hand, and can I ask that you keep your comment or question to 1 minute? Because I have a big sign telling me the time is over. Yes, please.
Yeah, thank you very much for the opportunity. My name is Dr. Mugisha Ntionza Nkoronko. I'm a general surgeon working at Benjamin Mkapa Hospital in Central Tanzania in Dodoma. I'm also in the Medical Association. I'm the sitting president. First of all, I want to register my appreciation for having this particular forum. In most of the meetings, we are missing the engagement of both public and private, having seated at the same table discussing how to move forward. I'm very sorry that we do not have someone from public sector at this particular moment in the government, and that I could consider as a setback in the movement of having PPP that is effective. Had it been, we have one there, probably our agenda could be, and our concerns could be very well articulated and listened to, and probably designed intervention that takes on board all of our concerns. Number two, what's the role of private sector in manufacturing, especially medical consumables, goods, and laboratory reagents? I have seen the growth of importations of this particular goods, consumables, and reagents more than having a local production. This increases the cost of care. I'm operating, when I'm doing a cesarean section, 70% of all the materials I use in performing this safe delivery, surgical delivery, are all imported. This makes that equitable access to better care varies across different levels in the public sector and in the private sector. Number three, my concern goes to about quality. When you look, I also practice in the hospitals that are owned privately. I have seen a growing concern of quality surgical care in private facilities. You find that the buildings itself are modified house, modified hotel. They are not meant to be a hospital per se. How much are we putting into regulation when we are incorporating private sector into the healthcare delivery and having standard facilities for delivering care? Lastly, but not least, in the areas of research, I have seen that what we use in the public sector is what we use in private sector. It is a standard now that you need a laparoscopic cholecystectomy. This is a gold band surgery. That is the standard across the world. But less hospitals in the public sectors are offering. It's just the referral hospitals, 2 or 3 or 4, and very few in the private sector. How are we going to ensure that private sector that has got the ubiquitous efforts and skills and resources to improve the quality of care in the other arm so that it can complement what people are missing in the government? With all due respect, I submit.
Thank you very much, Dr. Your points are very well taken, but perhaps the best voice or the best person to respond to many of those would be the public sector representative. So I'm certain the summit organizers have captured that, and hopefully we can have perhaps that has come out as some of the products from the session that go into the final report. I do want to call the session to a close. I loved every minute of it. I enjoyed the conversation, the keynote speakers' contributions to the discussions, and also from the audience. I'd like to thank you for giving us your time. Asanteni sana.